The Limi Children's Hospital is a multi-specialty children's hospital with advanced specialty in neonatology, pediatric cardiology, neurology, hematology, nephrology, and vaccination. We provide a variety of clinicians to help deliver the best possible care. Our physicians and nurses have been recognized by a number of independent organizations for overall excellence. We offer consulting services, regular nursery care, premature birth care, and treatment of babies with mild to severe illnesses across our different integrated facilities. Our neonatal intensive care units are well equipped with infant warmers, incubators, phototherapy, monitors, ventilators, and oxygen hood or nasal cannula. As a baby's and family's first pediatric caregiver, our neonatologists often begin their work by providing prenatal consultation to women experiencing preterm labor, carrying multiple babies, or following the finding of a possible congenital malformation that may require special preparation for the birth and coordination of treatment services for the infant. For more information, log on to www.limichildren.org.
Hospital, we are kicking off the webinar presentation today immediately, and we are so happy you're part of us. It's going to be a hybrid session today because we have a physical audience and also the virtual audience. I can see we are already 26. It's good time to start immediately. Right, so this is Limi Hospital. We have 3 hospitals under the Limi Hospital, government of Limi Hospitals. So we have 3 hospitals. Now, the Limi Multi-Specialty Hospital, which is at the headquarters in Central Business District, Abuja, where we have facilities for every other departments: obstetrics, gynecology, family medicine, surgery. Our obstetricians do IVF procedures. We also have the Cardio Care Multi-Specialty Hospital located in Area 11 near FCDA in Abuja, where we have high-end, high-tech cardiovascular interventional modalities, in addition to our seasoned cardiologists, our endocrinologists, nephrologists, neurologists. Our cath lab is set and one of the busiest in the country with diverse procedures going on. And the theater is literally set for cardiac surgery procedures. Today, we are broadcasting from Limi Children's Hospital, which is the 3rd arm of the Limi Hospitals. We are located in Ademola Adetokunbo Crescent in Wuse 2. And we have our services displayed on the screen, as you can see. We have pediatric cardiology services for diagnostics and preparation for interventions, which will soon commence. We also have facilities for neonatal cardiology, apart from the general pediatric cardiology. So we take care of newborn babies also. We have the pediatric nephrology, endocrinology, the neonatal intensive care unit, the neonatology unit, which is actually presenting today. Also facilities for neonatal transport incubators, our pediatric neurology unit, and the new developmental pediatrics clinics that takes care of children with autism and special needs. This display is neonatal echocardiography occurring on a preterm neonate who was taken to the echo room inside the transport incubator. Today we have an interesting topic, neonatal jaundice. We would like to look at current trends and challenges in management. I am Dr. Peter, and with me is Dr.
Chukwumeri.
Yeah, so I have a colleague here who we will take time to do justice to this all important concept. We will have a case scenario, and we would like you to listen very carefully, and then we'll be happy you answer some questions in the chat box that will follow. Let's understand your background information about this concept, then we drive through. This is a real life situation. So baby EJ is a female 31 weeker who was found to have yellowness of eyes at the 12th hour of life, and total serum bilirubin of 17 milligram per dl. The child was pale with a PCV of 27%. The mother has blood group O rhesus D negative, and she's a multigravida and has had 4 fetal losses. Father's blood group is B positive. Now, from these questions, what would you like our listeners to tell us?
Okay, from these questions, we would like to know from the scenario that we've created, what are the risk factors that we've highlighted, like list 3 of the risk factors. Then what comorbidity does this baby have? And what is the best modality of therapy that you would use to manage this child?
All right, very good. So we'll expect answers in the chat box as we progress. But just sit tight, fasten your seatbelt. The flight is beginning. Yes. So what would you want? What's the pattern of this presentation?
Okay, we would make a brief introduction, and we'll just talk about the epidemiology, possible causes, and then we'll go on to talking about the pathophysiology, the classification of neonatal jaundice. Then we'll now talk about the current trends. What are the things, how is it being managed? And what are the challenges that one can encounter during management of these babies with neonatal jaundice? Then we'll have a talk about the prevention and then conclude.
All right, thank you. So, what is neonatal jaundice?
Well, generally, it's a common clinical condition in the newborn, where there's yellowish discoloration of the skin and the sclera of the eyes of these newborns. The condition actually requires us to evaluate and treat the patient, because though it's benign in most of the infants, it could actually be very severe in some cases, and it could cause what we call acute bilirubin encephalopathy, that's causing damage to the neonatal brain, and then it has long-term effects. So in neonatal jaundice, the take is that you must diagnose it early and treat aggressively to prevent this.
Yes. So the case we've discussed, I'm sure it evokes the sense of urgency, emergency, yes, within the mind of any doctor at all. Let's look at the charts to see. All right, very good. We have answers rolling in already. Someone said rhesus incompatibility. That's the risk factors. Rhesus incompatibility, prematurity, anemia, extensive phototherapy. We'll look at that. Okay, fine. So now, yeah, so how common is neonatal jaundice? It looks like awareness is increasing about it. Yes.
It's actually a very common condition in neonates. And it's been found that in babies who are born term, that have completed 37 weeks later, most of them have it. Up to 60% of them have been found to have neonatal jaundice. And then in preterms, those that are born less than 37 weeks, 80% of them have been found to have neonatal jaundice. And then it just doesn't stop there. It's been found that every year, up to more than 1 million newborns actually develop the severe form of this neonatal jaundice, with most of them living in sub-Saharan Africa, like in Nigeria here and Asia. So it calls for us to be more aware and to know how to manage them.
Yeah, so serious. So out of every 10 preterm neonates, 8 of them will likely come down with neonatal jaundice. And so everybody, in fact, both the healthcare workers, the public should be aware of it and look out for it. So you mentioned severe hyperbilirubinemia. In those babies that have high levels of jaundice, and I think if we look at the question we posed earlier, that baby qualifies for severe hyperbilirubinemia. So these ones have bilirubin encephalopathy, in that there is the early effect of brain affectation, brain damage in these children. Some can die. Yes, it's benign in most cases. However, that baby has a risk, has risk factors, yes, that can even progress to mortality. You see, we'll look at that. Then the problem is, one of the major problems in long-term morbidities, disabilities, which is common in lower and middle income countries. So most of these children, those who do not die but survive, you survive with disabilities. Now, it's so painful, tragic to the pediatrician to find an adult who is intelligent but cannot use the hands, cannot use his legs. So you find someone say, I want to be an accountant, and this child is intelligent enough but cannot type on the desktop. So that's really, really traumatizing. So what are some risk factors of for this severe
forms, like prematurity, like in that the case scenario we have? Then hemolytic disease, that's where the red blood cells break up faster than they should. Like in babies born to, maybe the mother's blood group is O, and then the baby's blood group is B. That's what we call ABO incompatibility, which we find in that scenario. Then G6PD deficiency, which is also an enzyme problem with the red blood cell, and it's very common in our own environment. So the baby's blood cells keep breaking up, and so they produce a lot of the bilirubin, and even the rhesus is isoimmunization. And another common risk factor, which is also common in our own environment, is neonatal sepsis, infection in the newborn. It also increases the risk of the jaundice being very high in these newborns.
All right, having looked at the risk factors, I think it's time to take a second look at the questions we've raised. Oh, but I think we'll read the question again and allow some more people to answer. So we said baby EJ is a female 31-weeker who was found to have yellowness of eyes at the 12th hour of life. There's something about that time, about 12 hours, and had total bilirubin of 17 milligram per dl. I was found to be pale with a packed cell volume of 27%. Mother's blood group is O negative, and she has had 4 fetal losses. Father's blood group is B positive. We have some people who have already volunteered answers. Let's see. Yeah. So good. So we'll look at it. The risk factors for neonatal jaundice in this child. One is prematurity. The baby is 31 weeks old. So this is prematurity because 8 out of every 10 of them will have jaundice. Now, the mother and the father have incompatible ABO blood group status, and then the mother is rhesus negative. So ABO incompatibility and rhesus incompatibility. There are risk factors here. Already we see that the mother has lost 4 fetus. So it's just actually a real life situation. It's not a cooked up story anyway. The baby actually was lucky to have survived. Okay, fine. So what comorbidity does this baby have? If we look at it closely, the baby has anemia because this is hemolysis going on. So as there is lysis of the red blood cells, there's release of the bilirubin pigment, then the PCV drops. So it's a real life situation. So as for modality of therapy, we will wait. Let's go towards the end and see how that flows. Yes. So someone said 12 hours of life is a pathological jaundice. This person is really ahead. That's really, really good. We appreciate that. We've had other answers here from Chioma: prematurity, ABO incompatibility, resource incompatibility. Yeah, someone has already given us the answer to the therapy, but wait, let's make some progress. Okay, fine. Good. So etiology, if we look at the what will cause neonatal hyperbilirubinemia, it could be because the production of bilirubin is so high, or the excretion of bilirubin is so slow. So what are those factors that will cause increased production?
So increased production, like you said, if the red blood cells are being broken down more, so the child will have increased levels of this bilirubin. And some of the causes of this include the hemolytic diseases, as in where red blood cells actually being broken down, and it could be due to the immune mediated, like the rhesus alloimmunization, where the mother is rhesus negative and the baby is rhesus positive. So now the antibodies are now going to the baby and they're causing breakdown of the red blood cells. It could also be due to ABO incompatibility, where the mother is O, blood group O, and the baby is either A, B, or AB. So now the antibodies are also going to the baby and causing the red blood cells to be broken down. So by the time red blood cells are being broken down, bilirubin, more of it, or even hereditary diseases like the G6PD deficiency, and that one too will also cause more breakdown of the red blood cells. And you have polycythemia, where the baby's blood group, red blood cell mass is so much, so there's increased breakdown, and by the time there's that increased breakdown, there'll be increased production as well.
Yeah.
Or in some times when the babies have some injuries, like the babies on their head, they will have what we call the cephal hematoma. So the babies come out with like a mass on the head, and in a bid for the healing, the body breaks down the blood that has accumulated there, and there's also that increased production. Or in sepsis, infection, the organisms themselves that are causing the infection could also lead to the breakdown of the red blood cells. So all these would cause increased production, and then the hyperbilirubinemia the child will have.
Yeah. Okay, fine. So bilirubin pigment is inside the cell. Whatever breaks down the cell will cause release of the substance, and then it will be seen as jaundice. All right, so having discussed excessive production, there is decreased clearance as another risk, another etiology.
Yes. So by the time we go into the pathophysiology, we'll understand some of these things better. So when there's increased enterohepatic circulation, that means where the bilirubin has already been formed, and then instead of it going out, being excreted, maybe through urine or through the stool, it now gets back into the blood system. And this could occur in breast milk jaundice because there's something in the breast milk that stops, that interferes with this excretion, or in bowel obstruction in some children that are born with some maybe intestinal obstructions, duodenal atresia, intestinal atresia, where the child can pass stools. So instead of the bilirubin being excreted through stool, it goes back into the blood system, so it increases the level. Or some inborn errors of metabolism, they also all also reduce the excretion because they also interfere with the enzymes that help in the excretion, like the Gilbert syndrome, the Crigler-Najjar syndrome. These all reduce the conjugation of the bilirubin to the water-soluble forms that for excretion. So if there's that reduced production of the water-soluble form, the thing goes back into the system and into the blood, and then increases the level.
So whatever delays the excretion exposes the body to more the presence of bilirubin, and then it manifests as jaundice. All right. So we have this diagram that nicely depicts the metabolism of bilirubin. Bilirubin, like we said, is the pigment inside the erythrocytes, the red blood cells. So can you tell us more about how it is broken down, is transported, it is absorbed, and all that?
Okay, so what bilirubin comes from, it's part of, it's a product of the heme. In the red blood cells, there's the hemoglobin, which consists of the heme and the globulin. So when the red blood cell is broken down, it gives off the heme. Some other proteins also have heme, like catalase, peroxidases, and all that. So when there's that heme, it's acted upon by the heme oxygenase, which adds the oxygen, as in oxidizes it to give biliverdin. Then the biliverdin is now reduced by the biliverdin reductase to bilirubin. So this bilirubin is now transported to the liver for conjugation, and is usually bound by albumin. It's tightly bound, but this binding can be reversed by certain factors, some drugs, even some conditions in the body. So when the bilirubin is now transported to the liver, it's now acted upon by the glucuryl transferase to conjugate the bilirubin to the conjugated form, what we usually measure as our direct bilirubin. And this direct bilirubin can now be excreted via the urine, as in it's more water soluble, so it can easily be excreted. It gives the and that's what gives the pigment to the stool, as in the yellow pigment to the stool, and then it can also be excreted through the urine as well. So if at any time there's anything blocking that that obstructs the excretion through the intestine, like duodenal atresia or anything like that, you will find out that the bilirubin now goes back. It will now be broken off again. The glucuronil part of it, the conjugated part of it, will be broken off, and then the bilirubin goes back into the circulation, and then increases the bilirubin level again. Or even if, like I had said earlier, that bilirubin is transported bound to albumin. If anything reduces the level of albumin, maybe the child has hypoalbuminemia, that means that this child is also at risk of having hyperbilirubinemia, because most of it will not get into the liver for conjugation. So that's part of it. So, and this unbound bilirubin is the one that can easily get into the brain, crossing the blood-brain barrier into the brain. So those are the things.
It's okay, fine. So having discussed the metabolism, we talk about bilirubin and its excretion. So we said bilirubin is byproduct of heme catabolism when heme is broken down. Hemoglobin, the globin is the protein fragment, and then the heme aspect is broken down. So like he has said, the heme oxygenase breaks it down, acted upon by the biliverdin reductase. So a large percentage of it, more than 2/3 of bilirubin, is from red blood cells. But mind you, myoglobin, cytochromes, other compounds or still have bilirubin. However, the major producer is the red blood cells. When it is produced, as shown in the diagram that was just discussed, the one that is produced is unconjugated. The one that is produced is not yet attached to, has not yet been conjugated. So that form is hydrophobic. It is not water soluble. It is lipophilic. So it is soluble in lipids. So you remember the blood-brain barrier, we know that membranes are lipid bilayer membranes from biochemistry and basic physiology. So if we have a compound that is lipophilic, it can easily be transported across the membrane into the blood-brain barrier, which is a membrane, into the brain to damage specific parts of the brain of the neonate, which we shall look at. So the unconjugated form is transported in plasma in a reversibly bounded form to albumin. This transports it to the liver for conjugation, which has been well discussed. The conjugation process makes it now hydrophilic, water soluble, and that's why it can be excreted in urine. And then the other components excreted in stool. So this basic explanation at least sets the stage for us. All right.
Okay. So like we previously said, this unbound bilirubin can easily cross the blood-brain barrier, which is a bilipid layer, like we had said. And then it goes more to the neurons in the basal ganglia and the cerebellum. So this will explain the kind of features these children may have if they are acutely or even in a chronic state. So this damage will now lead to what we call the acute bilirubin encephalopathy, which if we don't intervene immediately will now become the chronic encephalopathy or the kernicterus, as we all know, which has long-term sequelae.
Yes, yeah. And we don't want to get to that point. Well, hello, dear listeners. We are happy to have you with us. I realize a lot of people are putting their emails in the chat box. There may be no need for that because once you've registered for the webinar, you would have the slides sent to the email that you registered. So that's automatic. So just feel free and continue enjoying the presentation. So one look at pathophysiology, factors that could reduce the binding of bilirubin to albumin, because it is the unconjugated component that can damage the brain that should bind to albumin and then is transported in plasma to the liver for conjugation. But whatever makes it not to bind can make it gain express entry into the brain. So what are those factors?
Okay, some of these factors include acidosis, like in children that have respiratory distress, hypoxia, like in the respiratory distress, or pneumonias, or even meconium aspiration. Anything that will reduce oxygenation in these children can predispose them more to this damage, or even hypoxia. You know, many times, like the babies, once they come in respiratory distress, even the preterms, usually give them oxygen. But this hypoxia has been found to even cause a damage to the blood-brain barrier and then increase the access of the bilirubin into the brain. Sepsis is also something else that can increase the chances because, you know, like I previously said, it increases hemolysis and then can also affect the blood-brain barrier. Then prematurity too. Preterms, their blood-brain barrier is also it's not well developed. And then some of these drugs actually
cause the
unbinding of the bilirubin to the albumin. So they bind more to the albumin, like ceftriaxone, and that's why you find out that most times in preterms we don't
in neonates we want to avoid ceftriaxone as much as possible. Okay, so we want to classify neonatal jaundice. Remember the case we presented, jaundice was noticed at 16th hour of life. Yeah, so there is a classification on the basis of time. If it's before 24 hours, it's really early. It's a problem if it's before 24 hours and late onset after that. Then the conjugated component and the unconjugated, and at times, especially in sepsis, there is a mixed picture also. We must bear that in mind. So it could be conjugated if the liver has acted upon it, unconjugated before the liver acts upon it, and then a mixed picture is positive. Then there's a physiologic and pathologic. We have two slides that will give us clear distinction between the physiologic and pathologic. Then on the basis of severity in terms of the level of hyperbilirubinemia and the clinical symptoms that ensue. So it could be mild, moderate, or severe. Good. So fine. So you tell us the difference between physiologic and pathologic.
Okay. Physiologic jaundice usually starts, usually say it's late onset. Late onset meaning that it usually starts after 24 hours of life, first 24 hours of life. It could make you think, oh, this could be a physiologic jaundice. But if it starts, any jaundice seen in a newborn on the first day of life, that's within 24 hours of life, you must always think about a pathologic cause, like in the case scenario where the baby's SB was noticed to be high by the 12th hour of life. Then the physiologic jaundice usually peaks at less than 12 milligram per DL, usually at the 3 to 5 days of life in the term babies, and then at 5 to 7 days of life in the preterm. And then the direct bilirubin, that's the conjugated part of it in the physiologic jaundice, is usually less than 20% of the total bilirubin. Unlike
so this an expression of the levels of bilirubin in physiology. So there used to be the graph that shows that everything is normal within the first 24 hours of life, and then you would have a rise up to, that's for 10 babies now, by day 3. Between day 3 and day 5, the graph reaches a plateau phase. It doesn't go beyond that, and 12 milligram per DL is the peak. So by the time you are seeing, okay, fine, the pathologic would explain that. So after day 5, it drops. For preterms, it reaches plateau phase between 5 to 7 days, then the graph drops. Okay, so what of pathology?
So in pathologic, just like conversely, in the term, it usually starts, like we had said, on the within 24 hours, first 24 hours of life. And then in term babies, usually have it rising more than 12 milligram per DL. And then in the preterms, it could be more than 15 milligram per DL, like in our case scenario, where the baby's own was 17 milligram per DL. So it also already tells you that this is pathologic jaundice. And then the direct bilirubin could be more than 20% of the total serum bilirubin. So if at any time you calculate it and it's more than 20%, you just know that this is not a physiologic jaundice, but most likely pathologic.
All right. Thank you. So we have, we can see loud and clear. We've seen your comments. We'll take necessary action. Okay, thank you. So still on the distinction between physiologic and pathologic, at any point we want to be careful with making that diagnosis. We have to be very sure, because it's a diagnosis of exclusion. So we must have taken a proper history. We must have evaluated as much as possible, and then we say, no, there is no need to worry. It's a diagnosis of exclusion. But it's pathologic when they look at the rate of rise really so fast. So a single, so if we had that baby EJ, and the baby had jaundice noticed within 12 hours of life, but we had a total serum bilirubin of 9 milligram per DL, and within 2 hours, someone feels something is wrong here, and then we'll take and we get 11. That rate of rise is fast. That rate of rise is fast within 24 hours. Now, if we have up to 5 within a 24-hour period, or greater than 0.5 milligram per DL per hour, it's pathologic, and we must act very fast. So there is always a cause for pathologic jaundice, and it must always be addressed aggressively, bearing in mind the comorbid pathologies that can ensue. So I want to discuss management. So we've tried to give we've given a brief overview of neonatal jaundice, laying a lot of emphasis on conjugated hyperbilirubinemia, unconjugated, knowing that conjugated is more of a surgical jaundice. Yes, fine. Okay, fine. So when we want to manage hyperbilirubinemia, we have a target. We do not want to have acute bilirubin encephalopathy. We do not want the bilirubin to cross the blood-brain barrier. And so early diagnosis is key. Now, the need for standard operating procedures in maternal units, that's postnatal wards, neonatal wards, and the fact that these babies should be assessed every 8 to 12 hours becomes very important. Laboratory assays become very, very important. Basic, knowing the level of serum bilirubin is of utmost importance. From there, we can now start checking to know all the other what is causing it. Because if it's sepsis, then there is need for, in addition to the general treatment we'll give for jaundice, there is need for antibiotics and all that. The diagnosis must be very, very clear. So fine. So we have an algorithm here because we talked about the steps to take when the neonate is found to be icteric. So
okay, so in every neonatal, in every unit where we deal with newborns, like in the maternity wards or even the neonatal units, like we said, we should assess these children clinically for jaundice every 8 to 12 hours. So if we assess and the child is jaundiced, you now ask yourself, what's this child's age? Is this child less than 24 hours or not? If the child is less than 24 hours, your mind goes to, could it be a pathologic, most likely it's a pathologic jaundice, and you'd want to know the level of the bilirubin. So you want to take off sample for the total serum bilirubin and the conjugated form too. So when you take this off, you interpret it based on the child's age in hours, especially if the child is less than 24 hours. And then based on that, you can now evaluate what could be the possible cause. So it's not just the total serum bilirubin you're going to be taking off. You're going to also check maybe if the baby's blood group, mother's blood group, the Coombs test, and all that. And then you also treat at that point. But if there's no jaundice.
Okay, yeah, so here.
If there's no jaundice, you would leave the child and assess. But if at any point in time you're observing this, yes, you still go back and take off samples for this child.
Yeah, okay, fine. It's important to know that in addition to the presence of jaundice, we look for risk factors. So we look for risk factors. So and then we act appropriately. If the child is the baby is not ready for discharge and there are risk factors, if yes, then we are following up. So the place for close follow-up of neonates becomes very important. So babies should be seen after 48 hours of discharge. And then part of the things we see, in addition to asking about immunization, feeding, cord care and all that, looking into the eyes become very, very important. So these are like an algorithm that must be followed for all newborn babies, regardless of the color of the eyes at the point of discharge, regardless, because even if it's not icteric, by the time one is following up, it's possible to have it. Yeah. Okay, so we want to look at how we assess for acute bilirubin encephalopathy in a baby who already has jaundice. Is a child's brain touched, damaged? How do we assess for that? So there is a bilirubin-induced neurologic deficit score, which was developed outside the country, but there is a validated form by Nigerian researchers that is validated for use in Nigeria. It's important to use that to assess the babies. So we have our chart here that is displayed on the screen. for all babies that have jaundice, regardless of the severity.
Yeah.
This is the minimum that should be done at the bedside or in the clinic.
Yeah.
And this should be done at first contact and should be done at least daily. But for some that will be rising very fast, it should be done multiple times in a day. So what are those clinical parameters we check? We check for mental status of the neonates, we check for the muzzle tone of the neonate, we check for the cry pattern, and then check for oculomotor or eye movements. This is very important to have this chart in neonatal units. So for the mental status, is the child normal? Everything is normal about the mental status. The child interacts with environment and the mother, then we score 0. If the child is sleepy but rousable, the child is sleepy, there is something that makes the mother feel. That's the instinct of the mother becomes very important here based on the questions we ask. Something makes the mother feel this child is sleepy more than the child should sleep. That's 1. We'll score 1. Now, by the time the child's feeding is decreasing, now babies want to suck, babies want to feed. That's what they are born for at that point. Just food, just food. But now by the time the baby is no longer sucking as eagerly as the baby was sucking at birth, it's a red flag. Now, is a child now lethargic, not as active as the child should be? Suck is poor, baby is irritable, and all that. So we score 2. The worst case scenario under mental status is that when the baby has some form of coma, that the child is no longer alert. Yeah. So is the child having apnea? Let's bear apnea in mind in a child that has jaundice. So we have apnea of prematurity, we have apnea on a but an icteric child that is apneic is a serious red flag. An icteric child that is convulsing, don't just say meningitis. Don't just leave it for something else. Look at it very closely. The brain is being touched. And coma. Any of these you score 3, so that's quite severe for them. That's really severe. Now we look at the muzzle tone. For mental status, you are asking questions. For muzzle tone, you are trying to examine the tone along muzzle joints. Now, is the tone normal? Then you score 0. Is there persistent mild hypotonia? Mild hypotonia, then 1. Now, moderate to moderate hypotonia, moderate hypertonia. Moderate hypertonia is you score 2. Increasing arcing of the neck. So by the time the neck starts bending backwards, it's a red flag. By the time we have the neck tilting backwards, increasing arcing of the neck and trunk on stimulation without spasm of the arms and legs. This spasm is important to differentiate it from neonatal tetanus from other things. So it's good to differentiate that. Though we don't commonly see it these days, but then it's important to differentiate. Now, persistent retrocollis, that is, it's just act backwards. You cannot place the child in supine position again because the neck has arced backwards. Opisthotonous posture, crossing or scissoring of the arms and legs, that one is really bad. So we score 3. Now we'll try to hear the cry pattern based on what the mother said. So, Ma, do you observe any change in cry pattern of this baby? At least you heard when the baby cried at bed and shortly after that, but now this is 2 days. What do you think about the cry pattern? Is it as it has always been? No, doctor, it's sounding so high. So now that's a high-pitched cry, shrill cry, or the cry that is not consolable. But there is still something as much as everybody who has passed through medical school that did jaundice knows high-pitched cry. Remember, there's weak or absent cry. That one is another very bad one. Yeah, so weak or absent cry in a child that previously had high-pitched cry and the child had jaundice. So no, my child has suddenly become so peaceful. He's no longer crying. And we don't know why the child is not crying and he's not even sucking well enough. It should have been sucking, but it's not sucking. But this child is like the father. The father is a very quiet person. That's a terrible thing. That's bad. So oculomotor or eye movements, we look at the normal position of the eyes. Then we look at the sun setting kind of appearance. So there is paralysis of upward gaze. The child cannot look upwards again. So we add up all these things and we see. The next slide will tell us the interpretation of the scores. It's important that this is done and that the parents are carried along during the process of scoring. This cannot be overemphasized because of the chances of denial. Denial. So it's not my portion, it's not my child, and all that. So it's very important they are carried along. Now, this is the interpretation of the score. So can you tell us about it?
Okay, so based on all the parameters, if at the end of the scoring, the child's total score is 0, then that means there's no acute bilirubin encephalopathy, and you tell the parents that. But if you score and the child's total score is maybe child has 0 in some places, 1, 2, and at the end it's 1 to 4, then that means that child has mild acute bilirubin encephalopathy, and that means that this type is actually reversible if the therapy is prompt and aggressive. So this is the type that you just admit immediately. You don't even wait for all the plenty lab investigations. You just want to do a double volume exchange blood transfusion for this child, and you want to start intensive phototherapy as well for this child. You don't wait for all the gamut of investigations. And then, but if it's 5 to 6, that's moderate acute bilirubin encephalopathy, it may be reversible with prompt bilirubin reduction, and you must communicate this with the parents so that they know and they don't deny later. Maybe if they're seeing some changes in the baby, they won't say nobody told them. But once it's 7 and above, then that means there's severe acute bilirubin encephalopathy. And at this point, you already think there's already some brain damage, and all you're going to try to, your treatment is actually get towards preventing further damage to this brain. Because you won't say, oh, it's already damaged, so let's leave it. Or you have to treat so that it doesn't worsen.
Yes. So this interpretation, it's so important, and permit me to say it has medical legal implications.
Yes, it does.
So by the day 1 at presentation, and we get a bind score of 3, the onus lies on the doctor that he must reverse. So bind score documented 3 and it doesn't reverse is a problem with the healthcare management. That's so we're on the tip of our toes when you get that. Now, so between 5 and 6 is moderate. It might. It might. So this is a point that counseling becomes very important. So say you tell the parent, madam, I would have to do an urgent double volume exchange blood transfusion. We might have a reduction. We are supposed to have, but it doesn't always happen. However, this is a place to give the window of counseling that there may be need for a repeat exchange blood transfusion. Because if the first one does not, so we've had situations where the first exchange transfusion was done and the doctor wants to repeat exchange transfusion, and the parents feel that the first one, something wasn't done properly. No, by the time it falls within this class, you want to do everything to bring it down. Counseling becomes very, very important. Greater than 7 and above, you are doing damage control. Is damage control. So I usually say for mild case, it must reverse. For moderate case, it may reverse. For severe case, it may not reverse. So these things is very important, but we don't want to get to this stage in the management. So by the time a baby is has a bind score of 0, and then phototherapy starts, and the next day you come, you get a bind score of 2, something is wrong. So we check, is this baby staying under the photo lamp, or are we having excessive mother-to-child bonding? Mother wants to always hold the child. No, this is my first child, or is the first boy in our lineage, all my people, they've always had girls. Now this is boy. No, no emotions here. So we have emotions as pediatricians, but none here at this point at all. So by the time he's moving from 0 to 2, something is wrong. Either with the irradiance of the phototherapy unit, or the fact that probably the child is not positioned under it, or bad as it is, which we will see if there's no light. If power supply is a problem, but we have a solution for that. And that's one of the beauty of the presentation today. Okay, fine. So now screening for the bilirubin levels. Yeah. So,
okay, so before any baby is discharged, even the child is not, the baby is ready to go home, there's no risk factor, there's nothing. Before you discharge this baby, you should do a total serum bilirubin, and you plot it on a nomogram. There's a nomogram that takes into account the gestational age at which this child was born, and then the neurotoxicity risk factors, which include if there's any ABO incompatibility, if there was asphyxia, and all those factors. This will help us to predict the risk for severe hyperbilirubinemia if this child goes home, and then the need for early intervention.
Yes. So before discharge, that must be. So this is the
nomogram.
Okay. So it stratifies babies into high risk zone, intermediate risk. So the high, intermediate, low intermediate, and the low risk zone. So if we take randomly that baby that was 34 weeks and noticed to have jaundice at 12, so we look at postnatal, this is 12 hours.
Yes.
Okay, fine.
And already this baby already has some neurotoxicity risk factors, like the ABO incompatibility, the prematurity, and then the rhesus isoimmunization.
Okay.
Factors.
Yeah, so, and then the serum bilirubin for that child was 17
already.
So if you look at the plot, the baby falls here is high risk.
Very high risk.
High risk. I will not want to discharge a high risk baby, especially in fact with those risk factors. Yes. So that's really high. So this is important. Yeah. Okay, fine. So we are assessing. So there is a icterometer that is used. It's just like the kind of ruler we have in mathematical set, math set. So it has a series of color ranges of different intensities. So it is with some gentle pressure on the nose of the child. That is why we said that, so someone has asked a question. I would like to know if the recording will be available via email. So recording will be available. We'll have recording. So recording in progress. So recording is in progress. Yeah. So we'll take care of that. And the link will be sent to participants. Thank you. So when we started, we said jaundice is yellowish discoloration of the skin or sclera. So you can actually detect jaundice in a child even without opening the eyes of the child. So we look at parts of the body where you can easily blanch, and the tip of the nose is one of such places. So using an icterometer, the baby is taken close to natural light as much as possible, close to the window, and it should never be done by just one person. We need to be two. It could be anybody, a doctor with a nurse, a doctor with any other person. So we look at it and then it's placed. So based on the color coding, which is labeled between 1 to 5, we check on the pressure on the nose, which one, the pressure on the nose makes us see one color. Where does it correlate more to? Is it number 1, 2, 3, 4, 5? So as we see it, and each number has its own bilirubin range. Yeah, so this is very important because you already know what it is before the lab result comes out. And so you can predict what the lab result should be. Yes. So that's now, icterometer should not be cleaned with spirit. If not, it will wipe off the color. Yes. Okay. Thank you. Yeah, so the transcutaneous bilirubinometer, yeah.
Okay, these ones, there are different gadgets that use this that can be used, and they are based on optical spectroscopy, as in based on the light absorption of bilirubin. So the the trans the bilirubinometer is actually placed gently over the sternum of the child, and based on the level it detects, it will give you a reading on the bilirubinometer.
Yeah.
So that's what it does. It's non-invasive, and at least you can use it to screen as many babies. Maybe, oh, this child looks jaundice, doesn't look jaundice. You can actually look at it, and it gives you an idea of what the bilirubin level could be. But you don't make your diagnosis and keep it with this transcutaneous bilirubinometer. You must always, once it gives you a reading that is high, you must always do your serum bilirubin.
Yeah.
Because that's what you can use to make your decisions.
Yeah.
And it also helps you to monitor the child when you're doing phototherapy. So you might not need to always be poking the child every day.
Yes. It's very, very useful, especially for monitoring. Yes, screening, monitoring, transcutaneous bilirubinometer is an electronic device, so it has to be charged so that we don't have some wrong readings.
Yes.
Okay, so there is the device. Okay, so there's this question.
Yeah.
Is the sternum the only part of the body we can use the bilirubinometer? If yes, is there a reason why?
Okay, it's actually there because that's where you can apply the gentle pressure, as in based on the area that you can apply the pressure and all that. So that's where it's recommended that you use it.
Yeah, so on the sternum, the skin there is light, it's very little subcutaneous fat, and gentle pressure can be there. Blanching is possible there, and then there is a firm surface. You can imagine putting on abdomen. No, it will cause too much discomfort. Okay, so the Billy sticks.
Okay, it's also part of it's also a new innovation, somewhat new innovation. It looks like a common glucometer and glucometer strip and all that. So you just need a little blood, just a drop of blood on the stick, which you insert into the machine, and then it gives you the total bilirubin level within 90 seconds. So you don't have to wait a long time for you to use. But if it's hemolyzed blood, as in blood that has already lysed, it will trigger off an alarm, so it will not give you a reading. Maybe it will give you error and all that. And this Billy stick has somehow we've tried to compare it to total serum bilirubin, even in our own setting and in Nigeria here, and it's been found to correlate somewhat to total serum bilirubin. So at least it gives you an idea, especially in the rural areas, in areas where you don't have light to like do the total serum bilirubin movement.
All right. Yeah, thanks. So just like checking random blood sugar, one can quickly check and be very sure. All right. So there's something new. At least our listeners will take home from here and should be able to use it by the bedside. So everybody just pay attention. Let's know about
Okay, there's this new SCB app that was developed in University College London, but they've done some studies even in Africa, as in Africa, I think in Ghana, to try to domesticate it down here in Africa. And it's an app that can be downloaded into any Android phone or even the iPhone. And it helps to detect severe jaundice in units by scanning their eyes. So you download the app and it gives you, there's like a picture of different color codes. And based on that, you use it to like scan the baby's eye. And the scan, it now gives you the whatever the color of the baby's eye now correlates to a part of the strip that's already on your phone. So it gives you an idea of what the level is. So it's something that you can use anywhere, even if maybe you see a child that is jaundice anywhere, even at home, you can give you an idea that, oh, this child needs intervention immediately. So I think it's a good innovation
Yeah.
in the management of neonatal jaundice.
Okay, fine. So listeners can check their Play Store and download the app immediately. There's a question here. Does the bilirubin show conjugated or is total?
Total.
It's total
It's
serum
total
bilirubin.
serum bilirubin.
It's total. Now there is another question. How do I interpret serum bilirubin result that comes in micromole? You divide by 17. Divide by 17 to convert it to milligram per dl. It's just like the conversion of random blood sugar. So random blood sugar, you divide by 18, bilirubin
by 17.
Yes, so that's it. Okay, so I've answered. Good. Okay, so we'll make progress. Phototherapy. So treatment modalities, or what strikes our mind immediately, phototherapy. So in phototherapy, we use light to convert bilirubin. Bilirubin, particularly the unconjugated fraction. And these unconjugated ones are hydrophobic. They do not dissolve in water. You understand? So you want to convert the hydrophobic bilirubin to its water-soluble isomers so it can be excreted in urine. So the unconjugated fraction cannot be excreted in urine. To just pool, it will just pool in the blood, which is not what we want. Its effectiveness is determined by the spectrum of light that is used. So you want to, this statement is very important. The effectiveness of the phototherapy unit or phototherapy source has some things. Now, the spectrum of light should be the blue spectrum, the irradiance. So we know that paracetamol has a dose. We step it up a little further. Oxygen has a dose. Let's now step it further. Phototherapy has a dose. Now, the dose of paracetamol is in milligram per dl. The dose of oxygen is in the fraction of inspired oxygen. The dose of phototherapy is in the irradiance. So if we have phototherapy units that the baby is under a phototherapy with serum bilirubin of 8, and then by the next day we have 13, and then bind score of 0, we have bind score now of 2. Something is wrong. Maybe that baby is just under ordinary light. Maybe the irradiance of that unit is getting weak, is fading. So you see, I normally tell the mothers, look, if you want to breastfeed your babies, which should be very short, switch off our photo unit, because as far as it is on, it is discharging the irradiance. So just switch it off, take your baby, clean up your baby, and put your baby back and switch it on. So there is actually an irradiance meter that should tell the actual irradiance of phototherapy. And we commonly hear people say, the child was on effective intensive phototherapy. The number of bulbs does not make it intensive at all. It is the irradiance that makes. So we said the spectrum of light. This is what we'll discuss when we talk about the halotherapy. Because people take their children under the light, under sunlight. What is the spectrum of light? What spectrum of light is that child getting? If it is not blue, you cannot filter off the blue. There is something you need to look at it close. Then the irradiance and then the exposure. If the baby is wearing that diaper, so the baby should, is controversial now anyway, where you talk of gonadal protection, but for medical legal reasons, well, leave it that way. However, the lower limbs, the trunk, the face, and the eyes, the eyes should be covered, the gonads covered. Apart from that, let the baby be exposed. Let the baby be exposed. So there are new innovations that can increase effectiveness. We will look at that. That is the purpose of the presentation. Well, let's see. There's this question. Thanks so much for this presentation. From your explanation, does it mean that acute bilirubin encephalopathy is reversible, while chronic bilirubin encephalopathy is not? Okay, so
Okay, yes, like we said, when we said based on the bind score, if you are getting a bind score of less than 4 and below, That means if you intervene very quickly and aggressively, you can reverse it. But if it's already at 5 to 6, you may be able to reverse the damage. You may not also be able to, depending on different factors. But once it's already severe form, maybe the child is already having all those choreatotoid movements and all that, it's most likely that the damage has been done. But the only thing at that point is that you don't want any further damage. But for chronic encephalopathies, that the damage has already been done.
Yes.
So at that point, you can't reverse it. So all you're going to do is just maybe physiotherapy for the child and all those things.
Yeah. So the kernicterus is a chronic long-term morbidity that follows the encephalopathy as we described. Okay, let's see if there's some other question. Is there any way to measure the irradiance, and must it be blue light? Yeah, so there is an irradiance meter. There's an irradiance meter. So every facility that has phototherapy should have an irradiance meter. So there are two ways. So better have an irradiance meter, or at the point of installation of the phototherapy, the manufacturers give countdown time. Yes. So as it's being used, the countdown time, it's so clear. So you see it counting down. And that's why I said, as soon as I'm near a phototherapy unit and the mother removes baby, I say switch off them. So we switch off the machine because it's counting down already. Using the irradiance. Yes, yes. What is intensive phototherapy, and does covering the phototherapy machine with foil and what? No, we will look at this. This question will be answered as we progress. There's this other question. Can the botanic nomogram be used in the management in telling if child needs phototherapy or EBT? If not, are there any other particular nomogram? So it's for risk stratification now. So let's go back to the chart. It's for risk stratification, and when you stratify risk, you act accordingly. So I'll say yes to the question. So those who are at high risk, so we said pre-discharge, you assess, right? So it's both for pre-discharge assessment and the need for intervention. So a child, like the scenario we painted, 31-week-old preterm. So we use the chart to describe it. 31-week-old preterm neonate with serum bilirubin of 12 milligram, 17 milligram per DL. The mother rhesus negative, both parents ABO incompatible. So if we look at it here, we said 12-hour-old, serum bilirubin 17. So the child is here. And then the other risk factors that we have already mentioned, prematurity, rhesus incompatible. So the child falls in, so it's high risk. The child is high risk. So high risk both for intervention and for follow-up. So okay. Maybe we would continue. So let's see if there okay, thanks so much for your presentation. Please, how effective is exposure to sunlight in the absence of a phototherapy machine in resource poor setting? There is a slide for this, so we'll handle that in very good details. All right. Okay, so we'll make progress. I think we will round up the presentation, then we'll start taking questions. Okay, fine. So
okay. Like we said before, that the phototherapy, it depends on the effectiveness, depends on the spectrum of light, and bilirubin is known to absorb light best in the blue spectrum between 460 to 476 nanometer. So that's how most phototherapy machines are built. The new narrowband light emitting diodes, they emit light at 476 nanometer, which is actually the peak wavelength at which bilirubin absorbs light. So you find out that when you put a child that has even very high levels of bilirubin under the LED phototherapy, within hours, it actually has a way of crashing it, because the bilirubin all absorb the light, and then they are now broken down to water soluble forms that can be excreted. So, and another good thing about them is that they generate very little heat, and so they are safe relatively to the baby's skin. So you're not afraid of burns to these babies.
Yeah.
So that's
Okay, so we've had situations where you have very effective phototherapy units. The parents come, oh, this child needs exchange blood transfusion. And by the time you get the donor and everything, the child has been under phototherapy, the child has transformed so much. So the baby on the table to commence exchange blood transfusion, the bind score has changed. Yes. When you have a very effective phototherapy unit, that's what happens. Okay, fine. So now, we said we're looking at innovations that can increase effectiveness. So Billy blankets.
So this is a Billy blanket. It uses a fiber optic system where a fiber optic substance, and you now put the light into the fiber optic substance. So you can use halogen bulbs, you can use your normal fluorescent bulbs, or even the newer ones use the LED lights. And the blankets, just like the name, you actually wrap it around the child. So here you're using, like, if it's one that has LED, that means you're using two things that are increasing the phototherapy. It increases the area of exposure to the light because it's all over. You just wrap it around the child's torso, and then the LED is also effective. But this is commonly used for home therapy in infants. But you won't discharge a child that has severe hyperbilirubinemia on this at all. So that means you've assessed this child and the bilirubin level is not so high, and this child doesn't have any risk factors that will increase bilirubin production before you discharge the child on these Billy blankets. And you're going to be monitoring this child like every day. The child has to still come in, even though the child is doing the phototherapy at home.
Yes, it's okay, fine. So so there is also the double surface phototherapy. So in this diagram here or image, we have the overhead phototherapy lab, and then phototherapy bringing out the light source from under.
So the phototherapy is coming from on top and below the baby, so it increases the area of the exposure as well.
Yeah. So we have in our center here, we have the Bilitron bed that can emit from beneath, and then the Bilitron lamp, focus lamp, that can come from above. All right. Okay, so fine. So this presentation, this slide now will answer the question about this should clear the doubt about sunlight and its use in phototherapy. Is it necessary? Yes, it is. Is it effective? Somehow, let's hear how it's.
Okay. So this there's a new innovation. It's called the filtered sunlight phototherapy, or the heliotherapy, where sunlight is filtered using commercial window tinting films. And then these films, what they do is that they remove most of the ultraviolet rays, leaving and then infrared light too, so that they now transmit just the blue light spectrum. So what it does is that the sunlight is all there, and then it removes the parts that may cause damage to this child, like the ultraviolet rays, infrared rays, and all that. They could cause damage and even sunburns and all that to the child, and just give you the blue light. And this innovation is actually very good for our Nigerian setting, where light, you might not always have light, as in power generation,
the
national grid has collapsed or even in rural settings where they may not have phototherapy machines. So this is actually a good innovation, and it's actually been tried in, I think, a health center in Lagos.
Yes.
They actually did a study and they found out that it could compare to children that had conventional phototherapy to an extent, but there was a lot of monitoring for the children.
Yeah, another advantage is that this one can permit mother to child bonding. So the mother is there with the baby, and you could have all the effectiveness of phototherapy. So the question still goes back. Someone had asked, sunlight. So we always say the discovery of phototherapy by a nurse, a white nurse, was because babies with jaundice, but those who were nearer the window was found, those ones were found to have clearance of the jaundice faster than the others. And so technology upon innovations that led to the development of the photo units. Yeah. So now, do we put our babies under sunlight? Yes, no. So you must weigh the options. Is it effective? Yes, no. So if we have the option of phototherapy, it is best. It's better. Phototherapy, just put phototherapy. But if not, we have seen that the electromagnetic spectrum has all the other bands of radiations, the ultraviolet radiation, the infrared radiation. So rather than not exposing the child to sunlight at all in a rural setting, it will be better to put under sunlight. But remember that the efficiency of the irradiance is based on we said the blue spectrum, the irradiance, and the level of exposure. The next question I want to ask, when people talk about it, is this is the windy weather, maybe in northern part. How comfortable will I be to put my baby exposed?
Because you have to
expose. Baby has to be exposed under sunlight. How long will I be able to sit with that baby under the sunlight? Well, I still insist that it is better to do that than let the baby get caniteric. But what is most important is let the baby be transferred to a center where phototherapy can be done. So it's a yes and no answer that leans more towards a yes anyway. It's a yes and no answer that leans a lot towards the yes. So heliotherapy is refining nature to suit resource-poor settings. Yes. Okay, so the other modalities of therapy in neonatal jaundice. So we have the double volume exchange blood transfusion, where you get the volume of blood. The volume of blood of the baby is 80 ml per kg, but double, so it's 160 ml per kg. So the blood is exchanged in aliquots through an umbilical venous access. Usually, parents must be well counseled on the procedure, the duration of the procedure, the possible risks of the procedure, but reassured because usually it's a safe procedure if it's well done. And it's actually a modality when we have bind score more than 0. Bind score more than 0, yeah, so 1 and above, the child should have exchange blood transfusion. So there's pharmaco. And then after exchange blood transfusion, usually the babies are still continued, phototherapy continues. So we will never exchange the baby and discharge because there's a risk of rebound. And then usually after exchange blood transfusion, the baby is new per oral for some time when the baby is on IV food before feeding will commence. So it's very important. So apart from exchange blood transfusion, there's pharmacotherapy, there's intravenous immunoglobulin use. So we'll know more about it.
So the pharmacotherapy, most of them are still, as in the use of heme oxygenase inhibitors. So the aim here is to prevent the production of bilirubin. You don't even want the bilirubin to be produced at all. An example of this heme oxygenase inhibitor is a methylporphyrin, and it's still being used in clinical trials. They're still doing clinical trials, so it's not yet being used for treatment. And what it does is that it reduces the total serum bilirubin by preventing prevention, and then it also reduces requirement for phototherapy because there's no bilirubin. The only side effect it has is transient non-dose dependent erythema. So the child will just appear red because the bilirubin is all there.
Yeah. All right. So I think the final one.
So the final one is intravenous immunoglobulins. Then this one has been found to be very useful in reducing the need for exchange blood transfusion in children that have blood group incompatibilities, especially in rhesus ISO immunization. So when you find a baby that's maybe the baby is rhesus negative, rhesus positive, and the mother is rhesus negative, you do a Combs test and it's positive, you can commence this intravenous immunoglobulins, but the child must be under phototherapy, intensive phototherapy. So what is done, the mechanism of action is actually not clear, and but it's said to be, maybe it could be due to non-specific blockade of some receptors that would reduce the carboxyhemoglobin levels.
Okay, fine. So these are experimental. Well, the pharmacotherapy is experimental, and this is obtainable. Yes. All right. So having discussed the clinical management, detection, monitoring, therapy, there are some challenges in the management of neonatal jaundice. And it's important that both the health workers and the community at large, they are aware of it. So these challenges are actually at individual and community level. Yeah. So some people have these misconceptions about the causes and treatment of neonatal jaundice. When we're talking about modified bind scoring, we emphasize that the parents be carried along. You never score a child and document and walk away. Why? Because we've seen then, way back during residency, you get people from rural area, you do exchange blood transfusion for severe bind score of like, let's say 9, 10. The baby already has brain damage. What you did was damage control, but they go in town and say, no, don't go to that hospital. If you go and they do exchange blood transfusion, the children are keneteric. This child was already keneteric before, was already having severe encephalopathy before. So what you did was just damage control. So it is not the exchange blood transfusion that caused the keneteric. There is that misconception in the community. And then about the causes, it's important that people know exactly the causes of. So we say once a mother has a boy, ultrasound shows that, oh, it's a boy. So we see it on the mother's status. The snap as it's a boy. So immediately as a doctor, it's a boy, tell the mother to remove camphor from all her clothes at home. So the boy that is coming does not want to enter a house that has naphthalene balls because of the risk of glucose-6-phosphate dehydrogenase deficiency. Yes, and then for those who have rhesus negative mothers should be well educated, and they need for Rogam, because if it's not taken and then it continues, yeah, those things. So there is a large dominance of home deliveries. It's known from public health that people's traditional birth attendants still take up to 70% of deliveries. So regardless of whatever we are seeing in the hospital setting, just know that we are just seeing the tip of the iceberg. So up to 70% is still being taken care of by traditional birth attendants. So they deliver at home, and these babies are kept inside dark rooms. Nobody is checking for jaundice. It's just there getting worse. And on the day of naming ceremony, visitors come. So it's done at the corridor. So you have visitors. Then one enlightened visitor notices that something is wrong. And the mother said, no, my baby is getting fairer. The baby is getting fairer. And someone said, no, this is wrong. So you see, dominance of home and poor health seeking behavior. Some people say they'll give Ampiclox. I've heard eye drop. I've heard Ampiclox.
Some people even put breast milk into the child's eye. All those things.
So all those things, delayed presentation. It's a real challenge. And that's the reason why enlightenment must be ongoing at every point, right from antenatal. Right from antenatal, a mother who has had a child with jaundice should think about jaundice in the next baby. Yes. Okay. So also challenges in healthcare system. Yes.
like out-of-pocket payments. Most people in Nigeria, they actually pay out-of-pocket. We just have few patients being able to access health insurance. And so sometimes when you even tell them, oh, this child needs to be admitted, needs phototherapy, needs exchange blood transfusion, you see a lot of them, they tell you, doctor, I cannot pay, especially in our government hospital settings, is actually a problem. So they won't be able to access the healthcare. Someone will even keep the child at home because they don't even have the money to get to the healthcare facility. And another problem we have is that we don't have any, don't have any national guideline on management. So it can cause non-uniformity in our management.
Yeah.
Yes, in some places, in some countries, they actually have, like, there's a guideline that you must do this, must do that, and all that. So even if we have like the flow charts that we showed at the beginning of the presentation, if it's something that can be domesticated and then put even in the rural areas, in the primary healthcare centers, or even those TBAs, you can even reach out to them and they know that, oh, once a baby is born, because our people, most of them, they tend to trust those TBAs more than they trust the doctors, as in they actually trust mama in their community, you know. Also, if mama knows that I'm meant to check if every baby that has been born at 12 hours of life, she will, if she communicates to the people, they will all believe her more.
Yeah, those people, they thrive because they've gained the trust.
Yes.
They've gained the trust of people. Yes. So something again is too early discharge, and it's tied again closely. Someone who is paying out of the pocket wants to leave the hospital as fast as possible because of cost. So when there are lack of facilities for investigation and treatment, it's a big problem. So and that's the reason why Limi Children's Hospital is making this presentation. I feel that one of the lack that is most serious is the lack of knowledge.
Yes.
So our babies are destroyed for lack of knowledge. So it's important that we are aware of one of the main facility we need is the knowledge. Now, then we now talk about very, very simple technologies like cerebral estimation is not expensive, but centers that can have other devices as simple as the iterometer can also check. Now, therapy should not be contested. Exchange blood transfusion when there is acute bereavement encephalopathy or the risk, it shouldn't be contested at all. That is very important. But every unit must have phototherapy units to take care of it. So if it's absent, that is where there is the problem. Okay, fine. Having said this, I think we are getting to the last slide, which is on prevention. However, let's see some questions. Let's try to attend to some questions that were raised. Okay. At what distance should the baby be from the phototherapy machine? And does this also affect the rate of pregnancy? Yeah, so we said the factors that affect effectiveness of phototherapy include the irradiance, the distance, the spectrum of light, the distance as close as possible. That is the answer, as close as possible. Then the exposure of the baby. So the closer, the better. But then the risk of burns coming. That's why the LED lights that emit less heat become very important. Yes. So which sunlight is preferable? Early morning, afternoon? Well, sunlight is sunlight. And that's why the argument about sunlight comes in. Sunlight is sunlight. Somehow the community has tended to prefer the early morning sunlight because, I mean, how many of us can stay under the scorching heat around 12 o'clock? But then, if we are using the helotherapy, whatever time of the day, one is prevented from the infrared, those other dangerous ones. So it can be at any time of the day, provided it's helotherapy. Thank you for the presentation. Is there a contraindication to giving routine immunization to neonates with neonatal jaundice? We want to avoid missed opportunities as much as possible. So the baby who has severe hyperbilirubinemia, is too sick and is on admission.
Yeah.
So, but if we find the one that we are taking as outpatient, no risk factor at all, the level is 8, level is 9. You mustn't wait for it to be totally cleared before you give, because we want to balance it. We do not want missed opportunities at all. Okay. Are there factors that can affect serum bilirubin results? Okay. Is phenobarbital still used in management of jaundice? Okay. Factors that can affect serum bilirubin results. You see, phototherapy, the light acts on the baby that has the blood. We are starting from the baby that has the blood to convert bilirubin to luminrubin, which is the soluble isomer. So if sample is collected in the wrong bottle, it's a problem. If it's collected in the right bottle, but exposed to light before analysis, it's a problem. Yeah. And then if the sample gets light before analysis, so bilirubin is a yellowish pigment that is intracellular inside the red blood cell. So let's say the level originally is 12 milligrams per dl. That is the one inside the serum. Yeah. But if the red blood cell gets light, we'll have more. So there will be a fictitious rise in the level of the serum bilirubin. So these are factors that can affect. So the place of phenobarbital. Yeah.
Really, yes, some have possibly that it can be used, but the problem is that it takes a longer time to start acting. And then you know that phenobarbital is also sedative. So it can even make you start thinking, oh, this child even has the acute bilirubin encephalopathy when the child doesn't, because the child will be more sleepy and all that. So that's why people tend to shy away from using it.
Yeah, so when they were using it, so currently is not really, so we have other more effective means, and that's why that's the reason for this presentation, the current thing. But it's in old textbooks, so that what it does helps in the binding of ligandin X, ligandin Y, so that the liver can get it and conjugate. So it's to enhance conjugation quite well. So once it's conjugated, the unconjugated fraction that can cause acute bilirubin encephalopathy is mopped up. Yeah, is reduced. So, but the essence of this presentation is current trend. So that's really an old practice, which most of our people who taught us were already professors then when they taught us. So we don't commonly use it. So is jaundice a contraindication for circumcision? So if the child is jaundiced on admission, receiving phototherapy, receiving exchange blood transfusion, you won't do circumcision. But the jaundice that is a tinge and you are getting 8 milligrams per day and the child is at home, does not stop us from circumcising the child. Just like what we said about immunization. Yeah. Okay, fine. So, wow. So we have quite some questions. The question is actually about intervention. That's about the Butani, that nomogram. Question is actually about intervention, specifically as regards phototherapy and EBT. What levels using the there's another nomogram for intervention. There's another nomogram. Yeah, so there's another nomogram for that. Yeah. Okay. The commonest causes of neonatal jaundice in the environment, from most common to the least, but we've discussed this. Well,
the most common.
Yeah, so okay, if you take it, prematurity is very common in our environment. And we said 8 out of every 10 preterm babies have jaundice. Then we know how common ABO incompatibility, sepsis is common in our environment. You can cause it.
Rhesus immunization, and even GC speaking.
Yeah, very common, quite common. So do the least common, you're not talking about the other rare blood group incompatibilities. Yeah. So please, what is the place of unripe pawpaw water in neonatal jaundice? Wow, This is interesting. What is a place? Okay, fine. I've never heard of this. I've never heard of this. And, yes, yeah. So, but we have to be very, very careful because as far as jaundice is concerned, time is of essence. The one that is jaundice that is already severe, you are now thinking of brain damage. Jaundice that you can still laugh around, you don't want it to increase. So we'll check more about the unripe purple water. However, the purpose of the presentation is to address current standardized management options. Yeah. Okay. In places where electricity isn't constant, like for 3 days, no light, then light shows up for 30 minutes and goes up. How can one do phototherapy? Is sunlight with UV filter an alternative, or do you have any other way to improvise one? Thank you. Okay, so well, so to answer this question candidly, in Limi Hospital we always have light. So apart from the national grid, that can skip sometimes, we always have standby power supply. So that's not a problem with us at all. So our babies are safe. But when we talk about rural areas where there's problem with light, power supply, we talked about the modified sunlight therapy. That becomes very, very handy because it will help to filter off the UV light, the infrared, and then we are just left with the blue spectrum. So that is very effective. At what level of serum bilirubin do you start phototherapy and exchange blood transfusion? Very good question. So this, to be very candid, there is a standard 20 milligram per DL of this alert point, but the different institutions have their standard operating procedures that could differ. The earlier one intervenes, the better. I'm talking of extreme blood transfusion. You see, when we talked about the slide of pathological jaundice, we say if it's rising greater than 0.5 milligram per DL per hour, or greater than 5 milligram per DL in 24 hours. So you want to intervene. So if I find the child at 12.5, and then in the next day I'm having 18, I'm going to exchange that child, even though we've not reached the 20 that is in the textbook. So that's for exchange blood transfusion. Now for phototherapy. For phototherapy, provided so at this one, at the level of phototherapy, yes, those charts, there's a standard WHO chart for phototherapy, which is still there, just like the botanic chart for discharge is there. So it's important to start at that point. So can you re-explain the reason why jaundice babies can't receive? No, I didn't say they can't receive. So a very good question came up. So in case I was misunderstood, just like I was taken out of context, like I'm not a politician. So if my expression was understood out of context, I am pro-immunization. And that's why I said that we do not want missed opportunities. We do not want missed opportunities. So that jaundice that we could still discharge the child with and say, come back for follow-up in 2 days' time, is not severe. That child can receive immunization. But that jaundice that makes us admit the child, place on phototherapy, do exchange blood transfusion, let's take care of that problem first before we do immunization. Okay, so what can you do to manage severe jaundice in a setting where there is no phototherapy and during weather like Harmattan or rainy season? Put a call across to us. We'll send our ambulance immediately. And even if it's a pretend baby, we have a transport incubator that will safely bring the child, because it's no joke. Severe, the question is not jaundice. The question is severe jaundice. We want to act as fast as possible. So because we don't want bilirubin encephalopathy. Okay, so prevention of hyperbilirubinemia, prevention of acute bilirubin encephalopathy, prevention of kernicterus. This is looked at from the 5 levels of prevention. What really comes to mind, someone thinks of primary, secondary, and tertiary. So, but they were talking of 5 levels. So the primordial level, the primary level, the secondary, the tertiary, and the quaternary levels. So at the primordial level, we want our healthy units to remain healthy. We want our healthy units to remain healthy. So we make sure that those who are healthy, anicteric, we don't want to prevent sepsis as much as possible, because sepsis is a very common risk factor for neonatal jaundice in our environment. That's why I said once the mother does ultrasound and say it's a boy, once we see the picture, the photo shoots of pregnancy, and then we see it's a boy on the mother status, we remove naphthalene balls from the house. Public health awareness. Yes. Let people understand that jaundice is really common, and that 6 out of every 10 babies that are born at term will have jaundice. Some of the jaundice will be physiologic, others pathologic. But whatever the case, no jaundice should be. Don't take the final decision at home. Get to a healthcare center. Let's assess and be sure that this is physiologic, this is pathologic. So if we keep those who are healthy, we empower mothers at antenatal visits with knowledge. We are doing prevention at the primary level. Now, at the primordial level. Now, at the primary level, those who have predisposition, you want to prevent it from escalating. Yes, from happening. So the mother who has rhesus, who is rhesus negative, she should be empowered with knowledge and should receive the rhesus D immunoglobulin, the ROGAM, should be received after every blood transfusion, even in young girls before they even think of getting married, after every surgery, after pregnancy losses, after every delivery. So there is a predisposition of rhesus isoimmunization in their offspring if the babies are rhesus positive. So we want to prevent this. And then there's a risk in boys who are predisposed to the glucose 6-phosphate dehydrogenase deficiency. And then in females that have Turner syndrome, we should also bear that in mind. So you want to remove the risk factors as much as possible. Address any child born to a mother that had a previous child with jaundice. That child is predisposed. You see, your older child, the child had phototherapy and all that. So you want to pick those ones out as much as so. Now, secondary prevention, those who already have the jaundice, you want to be very aggressive with treatment. That was why the question that came up and said where you don't have, I gave a candid answer that those where there is a problem, you immediately refer. This is secondary level. Jaundice has occurred. We must be very aggressive about it. Sorry, back to primary prevention. Babies whose mothers are rhesus negative, don't discharge those children in just 40. Those babies should be monitored by a pediatrician as close as possible, because it can rise so fast. At the point it's noticed, it can escalate so fast. Yeah. So we said for the secondary level, hit it hard as it is seen. Tertiary level, there is already, so the babies who are already at severe bilirubin encephalopathy already fall within tertiary because the damage has been done. So the extreme blood transfusion done for a baby with bind score greater than 7, you are doing tertiary prevention. You are ameliorating disability. Now for the quaternary, those they've grown up, they have problem with, they have cerebral palsy, which is said to be disorder of posture and movements that occurs from a non-progressive injury that affects the growing brain. Yeah, so in that instance, there's a problem of posture, problem of mobility. You help them with maybe motorized wheelchairs, and all that.
Yeah.
So I think that's quaternary prevention. But we want the community to stop at secondary. As much as possible, we want to stop at secondary. And if all the updated modern therapy is strictly adhered to, very likely we won't go beyond secondary level of prevention. Well, we thank our listeners a lot, but we'll conclude.
Okay, we'll conclude by saying that neonatal jaundice is actually is a common cause of morbidity and mortality in children, and early diagnosis and treatment are required to prevent these.
The mobility
and the mortality. Yeah. So all hands must be on deck to do this.
Yeah.
Thank you.
Yeah, thanks. So referring the baby that has jaundice is not luxury, it's for the good of the baby. So services, a child that should be exchanged, the child comes in, I've come to the hospital to do a blood transfusion around 1 a.m. So a consultant does not hear the child has severe jaundice and waits till morning. It doesn't happen, because once you do that, the level reverses immediately. You are very happy. So our babies get very, very good care. So it's as aggressive and as serious as that. So let's look at some more questions. Okay, yeah, thank you. So we have our friends from diaspora. So there is a link already for participants to go through. There is a link that was shared. Yeah, okay, fine. So it has been shared again. Yeah. So someone asked if there's a link. Okay, fine. So let's see. How do we detect breast milk jaundice when we have a case of neonatal jaundice? Okay, fine. So as regards breast milk and jaundice, there are two types of jaundice. There is a breastfeeding jaundice and there is a breast milk jaundice. So the breastfeeding jaundice occurs early within the both are found in the first week of life, whereas breastfeeding jaundice within the first 2 days, whereas the breast milk within the last 2 days. So that makes it really, really easy. And the breastfeeding jaundice, mothers who are not lactating enough, and then they are giving babies glucose water, giving baby plain water, caloric demand is high, and the baby is not getting enough. Those ones are commonly dehydrated and they can have breastfeeding jaundice. Well, that's breast. So, right, if I have my way, I'll call it breastfeeding deficiency jaundice. That's the breastfeeding is not coming. But for breast milk jaundice, that one is after other causes have been excluded, and because of the increased enterohepatic circulation, the breastfeeding can be temporized for 24 hours. There will be a rapid drop. There will be a rapid drop. So yeah, so I don't think anybody treating jaundice in children should guess the cause, the etiology of the jaundice. So even if I think the child has breast milk jaundice, you must rule out ABO incompatibility, rule out sepsis, do all the investigations, and when it's done, you notice a diagnosis of exclusion. At this point, you temporize breastfeeding, come back, and you are done. So I think that's that. Thanks, dear listeners, for your attention. We've kept you engaged for this close to 1 hour. These are references. Thank you for your kind attention from the babies in Limi Children's Hospital. Thank you all.
Thank you.
Yes. Yep. So the CMEs will be sent to your email addresses. Yes. Yeah. So when
Welcome to Limi Hospital, where we build a long-standing relationship based on excellence. We have provided quality healthcare service for over 30 years. We focus on exceptional customer service, patient satisfaction. Our accommodating hours and friendly staff are an essential part of our long-standing success. We consider every patient as a member of our extended family. Our commitment to you starts the moment you step into any of our hospitals. Personalized patient care is what sets LEMI Hospital apart. When you visit us, you can expect to receive world-class care. Expert physician specialist and caring clinical staff provide you with an exceptional healthcare experience. We accept most of the health plans, both for self-paid patients and all insured patients enlisted in the National Health Insurance, and are registered with a large number of HMOs in Nigeria. Our low prices help those with high deductibles and co-pays. Please call us to verify as we take your health insurance and for special rates for self-paid clients. For more information, log on to www.lemihospital.net.